Kia ora e tiwi. Nau mai haramai and welcome to this evening's Centre for Health Hauora Korero. Ko Natalie Hilterman tōku ingoa, and I've got the privilege of facilitating our Korero i tēnei pō. We will be discussing with this amazing panel what good heart health looks like. As we all know, e te whānau, a healthy heart is central to overall good hauora or good health. Embracing a healthy lifestyle at any age can prevent heart disease and lower your risk of a heart attack or stroke. We are never too old or too young to make lifestyle changes that will improve the health of our hearts. So I hope with this evening's kōrero is that for our whānau watching at home, you'll be able to get some little nuggets of gold and maybe possibly make some small lifestyle changes for the better, for you to live your best life. So shortly we'll meet tonight's amazing panel who'll be sharing their insights, whakaaro and expertise with us. If you have any specific pātai, if you hear something throughout the night, please just DM us or pop something into the chat below and we'll ask our expert panel what their thoughts are. But first, I'd like to open our hauora kōrero up with a whakatauki. So Anna, can you please open our kōrero up, please?
Sure. Thanks, Nat. Ko Māori e te whānau. Tonight's whakatauki might sound familiar to some people. It's often a verse that is used to open a whai kōrero. When someone stands to speak at a formal occasion, this is what I'm going to use today to open us tonight as sometimes used in that context. But it's really relevant for our conversation this evening. Ka tangi te titi, ka tangi te kaka, ka tangi hoki a hau, tihei mauri ora. And what that literally translates to is the titi or the mutton bird is calling, the kaka is calling, which is like a parrot, and therefore I am calling, and tihei mauri ora means behold, there is life. And so it's a really good whakatauki to open us tonight for our kōrero about heart health, because we so often take for granted our hearts, and actually without it there is no life. Heart disease is modifiable and preventable, and so actually there's quite a lot that we can do to change our lives and to improve the quality of our lives and to improve get a bit of a longer life by thinking about what we can do for our heart health. So really grateful to our panelists who are here this evening, and hope you guys enjoy our kōrero this evening. Kia ora, Nat.
Oh, kia ora, Anna. All right, whānau, we'll just do a quick round of whakawhanangatanga so you can get to know a little bit about who our panel are. I'll start with Hannah. Do you want to introduce yourself, please?
Kia ora, everyone. I'm Hannah. And yeah, I'm a clinical exercise physiologist at the Centre for Health. So I get the privilege of leading our awesome exercise clinic and clinical team there, and supporting everyone on their health journey in that space.
Oh, kia ora, Hannah. Katrina, did you want to introduce yourself and where you're beaming from too, please?
Kia ora everyone, I'm Katrina Poppy. I'm beaming from Cambridge in England at the moment. So this is morning light behind me, which is quite nice in spring, although it's really cold outside because it is England. So I work at University of Auckland these days, and I'm involved in a lot of heart research. I used to be, back in my past, I've been around for a while, I was a clinical cardiac physiologist. So I worked in heart stuff in the hospitals, and then I got into statistics and research, and so that's really what I work on now.
Awesome, thank you, Katrina. Martin, did you want to introduce yourself, please?
Kia ora tātou. My name's Martin Stiles. I'm a cardiologist at Waikato Hospital, where I've been working for the last 15 years as a cardiac electrophysiologist. So my main interest in heart health is to do with electrical disorders of the heart. So I put in a couple of pacemakers today, a defibrillator, and we fix somebody's fast heart rhythm as well. So those are sort of procedures that we do. But I also look after cardiology patients on the ward, so people coming with heart attacks, people coming in with heart failure, and other sort of heart disorders. So yeah, in New Zealand, most of us are generalists because we all have to pitch in on the wards. So that's my background. I'm really happy to be here tonight, and thank you very much for the invitation.
Oh, amazing, Martin. Karen, did you want to introduce yourself, please, next?
Hi, everyone. I'm Karen, and I'm 63 years old, married with 3 adult children, and yeah, I had that little old heart attack, so you'll hear more about that soon.
Thank you, Karen, and thank you for sharing your journey with us tonight. And finally, Anna, can you please introduce yourself?
Sure. Kia ora anō te whānau. I think most people out there know who I am these days. Ko Anna Rolliston tōku ingoa. I'm kai whakahaere at Manawa Ora, the Centre for Health. And yeah, thanks so much for coming and watching. Hopefully, as Nat said, you'll pick up some little nuggets that'll be super helpful for your ongoing hauora. So kia ora.
Oh, kia ora, Anna. All right, whānau, let's kick off. Our first parto for this evening, which I'm going to open up to the floor, and if nobody goes first, I will start picking on people, is what does good heart health look like to you, please, panel? Does anybody want to go first? Martin.
So,
Smiling a little bit more.
yeah, so good heart health, I see a lot of bad heart health. I guess that's my job. And so a lot of the time I spend trying to get those little incremental benefits from patients, whether it's lifestyle changes, whether it's medications, whether it's procedures, just trying to incrementally improve things. But I guess if you get to step back a bit and think, well, what's good heart health? I think it's just people appreciating the sort of risk factors that they carry and doing things to try and minimize the bad stuff that can happen to their heart. So that's going to be different for everybody. And you might want to think about what's happened in your family. You might want to think about your environment, your habits, whether that's exercise, smoking, that sort of thing. And I'd say it comes as a package, I think. And trying to say what's good heart health simply is a difficult question. So that's what I'm going to say, and then sidestep for someone else.
I love it. Hospital pass to Hannah.
Yeah, and I think sort of carrying on from what Martin was saying there, obviously we get the joy of working with people in their rehabilitation journey. So from that context, good heart health is being able to live life without a worry or concern that your heart is in some way debilitating or at risk of having something else happen. So being able to carry on with life and actually hopefully live an even healthier and more quality filled life than you were before. And then from me on a personal level as well, because I know, and we're going to talk a bit about stress, but that impacts heart rate and all sorts of things. And so for me, good heart health is literally being able to do whatever I want, which usually involves high intensity exercise for a prolonged period of time, without worrying about anything detrimental happening. Yeah.
Thank you, Hannah.
And that was, see, I'm not even going to be prompted. So, and that what you say, Hannah, is exactly leads into me, but it's a different case study, if you like, is that good heart health to me is being able to not be inhibited by your heart and body. And so as a personally, I do not do high intensity exercise and run for long periods of time, but I want my heart to keep up with me and not stop what I want to do and what I need to do. And so I dash across the road 7 minutes before we meet tonight and to get a coffee. And I could do it. My heart rate didn't race off. I didn't get unusually short of breath. I got no pain anywhere or just feeling weird or sick or anything like that. So I can do that. But it's a two-phase thing, I think. That's here and now, but I've got to keep whatever I've been doing, the good things of whatever I've been doing, but keep it up, because my risk, I do a lot of my research is around risk, and the risk goes up as you get older just because you've been around longer. So I need to make sure my good habits they're not great habits, but I need to always work on them and improve those good habits to sustain and future-proof my heart health as well. So I think it's a two-phase thing. It's the here and now, and then it's the going forwards, because it is a lifelong thing. We only have one heart and we've got it for life. So let's take care of it.
And I think, Anna, you mentioned this earlier, it doesn't mean we can't get good heart health as well. Like if we start focusing on stuff to do. Did you want to kind of carry on with that? Because I think some whānau kind of think that I've got a bad heart and that's it, but that's not necessarily the case, is it?
Yeah, absolutely. In fact, we did a piece of research here in Tauranga, I don't know how many years ago now, maybe 5 or 6 years ago, where we found that whānau thought that because heart disease was in their family, dad had it, granddad had it, auntie and uncle had it, that it was inevitable, and actually it's not. Certainly there are lots of environmental factors. You grow up in the same environment as your family, so you do the same things, and there's some genetic things that can happen as well. But actually, there's, as I said at the very beginning, there's heaps of stuff that we can do to make our heart a little bit better than it is now, improve it over time, or as Katrina was saying, if it's super healthy and great at the moment, how we keep it there so that we've got that for a long period of time. But my little chip in for what is good heart health is kind of a little bit different to what everyone else has said so far. Not that I disagree with anything that anyone said, bang on, but actually from a kaupapa Māori or a more of a holistic perspective, actually good heart health is about joy, happiness, feeling good about yourself, knowing that your family is well and happy, feeling really grounded in who you are, you've got a purpose in your life, that you feel like you provide service to your community. All of those types of things are also good heart health. So we have to have all the physical aspects 100%, but that's not the only thing. All those other aspects, if you think about the symbol of a heart, the symbolic heart picture that we all draw, whatever that means to you, those emotive words, that's good heart health.
Oh, I love it. I love that description, Anna.
And for me, just it was physically fit and active life. And it wasn't really until my heart or any other part of my body that's not functioning properly, until you realise that if you have an issue, then you have to work on things.
Oh, kia ora, Karen. That's so true. As with any aspect in life, right? Your heart is no. Okay, ka pai. Katrina, with the research you're conducting, if we're talking about heart health, what are the main risk factors to consider when we're talking about heart health?
So these are the things that they've almost become known as everyday things to look out for, because they affect a lot of parts of your health. And so they are keeping your blood pressure, not having high blood pressure. So if your blood pressure goes up too high, it can put a lot of strain on your heart and blood vessels. Blood pressure needs to be kept lowish. Cholesterol, so the total cholesterol in your blood, and there's you can have a blood test and you get quite a few numbers back on that, and they get combined in different ways. So different markers in your blood about cholesterol, you want that to be kind of low. So that involves not having a high fat diet, and other things like that. And diabetes. So if you have diabetes, that puts you at, can potentially put you at higher risk. I'm just talking risk. It's not a guaranteed. It's all just a risk, a potential to have a greater risk of having heart disease with that. So to keep body weight down, keep active, that will help lower your risk of developing diabetes, eating healthily, not eating a lot of sugar, not eating a lot of fat. All of that combines to reduce some of those common risk factors across that increase your risk of having heart disease.
And so all of these risk factors, so if whānau are concerned about some of them, how do they find out about them? They go to their GP, they have a blood test, and all of these risk factors can be determined through a blood test, or?
Some of them can be through a blood test, yes. I mean, it's key to go to a GP at some point. I have a friend, for example, she's the same age as me, and she hasn't been since she had her children 20 years ago. And I was like, well, possibly should, it'd be nice to check. So one blood test could look at what your blood glucose is, so can see that that's at a low enough level so you're not at risk of developing diabetes, or that you don't have diabetes. So that's the blood test. The same blood test, a different tube, they can look at your cholesterol, so look at your lipid levels in your blood. And then also by going to the GP, they can measure your blood pressure and keep an eye on it as well, because your blood pressure changes minute by minute, day by day. But if it's looking a bit high, then the GP might like to measure it again over subsequent periods of time. So it's well worth going to GP just to get like a health check, really, and to check where these things are at, because it doesn't mean they might all be good, or they might be a little elevated, and the GP can start to do some, talk with you about what kind of things you can do to help yourself lower some of those risk factors and therefore lower your risk. So a lot is in your control as well. And if it's beyond that, then there's other things that can be done. There are a lot of options and possibilities. And it's good having that relationship with a doctor in the community, or the practice nurse can be involved, depends how it's set up in your area, to help work with you on really maintaining good health.
Thanks, Katrina. Karen, did you, as our expert on, going through this journey, and thank you for sharing your journey with us tonight, but were you aware of any risk factors, or you opened your kōrero with you were fit and healthy? Can you just give us a little bit of an overview of kind of your hikoi with heart health?
So, yeah, I've always been active and outdoorsy, and along with that, a good diet. I had no cholesterol issues, and yeah, so I didn't anticipate a heart attack. I guess the thing that I didn't understand was the degree of stress I was under, and it wasn't a crisis situation stress. It was just a year after year after year after year of busy working life that I had become accustomed to. And the good old thing that people say is give a busy person a task and they'll get it done, and that was me. Yeah. So
when you had your episode, other than so you're fit, healthy, eating well, no risk markers, you tell me a little bit about what happened when.
Okay, so I had my heart attack a few days after Christmas Day, and Christmas is the busiest time of year. My husband and I own a business, have done for 26 years, or this particular business, and we work very long hours. So in that time of year, we were having dinner at 9, 10 at night, falling into bed and repeating the same the next day. So before Christmas, I just really wanted to get Christmas Day over and done with. Everyone comes to our place and we're not a big family, so everyone comes for Christmas. And my thinking was, once it's over, I can just relax. Everyone can look after themselves. And then my son said on Boxing Day, let's go for a walk up Otanawanuku, which we did. It was a hill, not a hard walk at all. And a few days later, he wanted to do an overnight tramp. He had treated his girlfriend to tramping boots. And yeah, so I wasn't particularly enthused. I just really wanted to rest. So I dragged the chain a bit and finally got ready the morning we were due to go. We were going up to see the sunset. So we left about 3 o'clock in the afternoon and off we went. And because we were only going not far in the bush, just 3-4 hour walk in, and we didn't know if the hut was going to be full, and it was only a little hut, so we took tents and we took lots of food and everything you normally wouldn't take on a longer tramp. So as we left, yeah, we tramped in half an hour or so before my episode. We took photos and everyone was happy. I was smiling. I just had a new sports bra on though, and it was tight and I felt it tight. And I just couldn't wait to get the thing off. But anyway, we tramped on. I was feeling a bit weak, and we'd had a late brunch, so I just thought I hadn't had enough protein that morning. So got the nuts and scroggin out and ate that. And we tramped on again for another half an hour, sat down, watched, looked over Matamata. It was fabulous. It was a beautiful late afternoon. And again, I had this desire to get this tight bra off and have some more scroggin. I was feeling weak. No alarm bells at all. I just felt, I hadn't had enough protein. So onward we tramped, and I have been treated for asthma for the last 14 years, but I don't have asthma attacks as such. And so I thought, well, this is an unusual feeling in my chest. I thought perhaps I just needed some Ventolin, really, and that would keep me going. And the only reason I did that was because my husband said that I was walking a bit slowly. He'd take my pack and go to the hut and we'd see him there. And with that, I took Ventolin and it basically crippled me. I couldn't do anything. I couldn't lie down. I couldn't sit. I couldn't. And my son and his girlfriend were still with me. And he took control and sort of said, get her in a sleeping bag. And he said, I'm going to make the call. So dialed 111. And luckily we had reception because I'd left the locator beacon at home. And which was just because we were only going into the Kaimais, not far. And with that, the helicopter came, paramedics winched me off, and I saw the sunset from the helicopter. But really, when they said it was a heart attack, I was in disbelief.
I was going to ask about that. So
yeah.
Because we've just heard from Katrina about some of the risk factors and things to look for, but you didn't really have any risk factors that you're aware of though, right? In terms of low cholesterol, but stress.
Very stressed. Although, well, I present well, don't I, Hannah?
Certainly do.
I think I was carrying, probably 10 years earlier, I was carrying a lot more weight, and my blood pressure may have been elevated then, and I dropped the weight off and it went back to normal. Beyond that, it wasn't even a consideration that I had any heart issues. The focus had been on my chest.
So that's what you were feeling. You were just feeling kind of constricted. Your breathing was a little bit constricted until you had the Ventolin.
Well, it was probably more when I am going up hills, I do tend to use the Ventolin to help me. And I had said that when I need Ventolin, often I get this unusual sensation in the back of my throat, like almost an unusual taste. I didn't have that. But after I had the Ventolin, what I did feel was like a huge flash of lightning that I can just describe it as an orange flash across my chest that stayed there. So that was the unusual sensation.
I'm gonna jump in if that's all right, because I've just some things have just sparked in my head from your conversation, Karen. Hey, Katrina, I know that some of your expertise is in women's heart health, and is it true that women tend not to get the same kind of signs and symptoms that they're about to have a heart attack that men do? Because it sounds like this is what Karen's describing.
Yeah, definitely. I mean, maybe Martin, he sees more of this than I do. You know, you get the front line there, Martin, seeing people come in, but there can be differences, can't there? They can be the same, like this crushing chest pain, but there can be many different ways of feeling a heart attack. Martin, what would you say?
Yeah, there's lots of different ways, and this sensation of tightness across the chest is really common. We see it all the time, and like you describe it as a physical restriction, like a bra being too tight. The woman heart health is really interesting. So, I mean, I've read conflicting evidence about how women present possibly differently. Sometimes other papers say they present the same, but I think the other thing is that traditionally women haven't seen themselves as potential heart attack. So perhaps they're more dismissive of the symptoms. And I think the health professionals have to take some responsibility for this too, because, you know, heart attacks are more common in men. It's about a 2/3, 1/3 thing. And, you know, so perhaps women are more likely to be diverted into having anxiety or some other, you know, diagnosis. And I was really interested to hear that you gave yourself a Ventolin stress test on the mountain, Karen, because, you know, one of the treatments that we use for heart disease and angina is a beta blocker. The beta blocker tablets, so they're beta adrenaline receptor blockers. And what Ventolin is a beta agonist, so it's a beta adrenaline, you know, mimic. So you're just, you know, giving your heart a bit of a workout, and look, there you go. You know, the Ventolin stress test on the mountain. I think that's yeah. And did you come to my hospital or did you go to Tauranga?
No, I came to Waikato. Yeah, I came to Waikato, and it was, I mean, the team was fabulous. The paramedics, when I had my heart attack, I was in the bush as such. And I don't know how I managed to rally strength, but I had to get out of the bush. And the closest clearing I could get to was a big slip on the side of a mountain. And that was it. By then I was pretty sick. I was very nauseated and not looking good, according to my family. Yeah.
So Martin, if somebody, you must have just been coming off your 40-hour shift at Waikato Hospital while you didn't see Karen, but why and in what context should medicine play a part in heart health?
Yeah, well, you know, us doctors, we love tablets. We love to give medicine. Go away, take these 16 tablets and you'll be fine. But I guess, you know, it's got to be a package deal, isn't it? The patient's got to do stuff for themselves. We're going to do stuff for the patients. There's expectations that we have what the patient's going to do. We hope the patient's going to fulfill those expectations. Some of them do, some of them don't. And we try and encourage them to do that. Medicine's a really important part of heart health for patients who have heart disease, and also for patients who potentially might get heart disease. And I reckon you could probably divide these medications into two sort of groups, really. One group is the medications that make people feel better. So when you do have asthma and you take your Ventolin, you feel heaps better. So of course the patient's going to take that because they feel better immediately. So those ones aren't difficult. So those are sort of symptom relievers, right? The more difficult ones that to get patients to take and get them to take long term are the disease preventers. So we say to patients, hey, if you take this tablet to lower your cholesterol, say, the chances of you having heart disease over the next 5 or 10 years is much less, but they don't feel any different, right? Whether they take the tablet or not. So trying to convince the patient that they want to take these tablets can be quite difficult. The ones that make them feel better, no worries at all. They're going to take those anyway. It's those other ones. And so what we tend to do, and it's a very medical model of how we think, but I guess we're doctors, so we're allowed to, but, we have trials where there's thousands of patients. Half the patients take this drug, half the patients take a different drug, or maybe a placebo, a sugar tablet. And at the end of a year, 2 years, 5 years, you count the number of events in each group. And if there are less heart attacks, less strokes, less deaths, and the patient's taking the tablets. Well, it's a bit of an easy sell to say, you know, this is a useful medication. But for us to then say to a patient, individual patient, because of these trials and because of what we know, if you take this tablet, you'll do better. There's a bit of faith that the patient's got to have in us, and we have to build the trust with the patient so that they will fulfill their part of the bargain.
And I think just sort of, sorry, Nat, kind of adding on to that as well, from us, from a practitioner point of view, when we're trying to help people, either it's a preventative strategy or rehabilitation, and engage in exercise in particular. Now, exercise obviously is awesome and everyone should be doing it, but it can increase things like your heart rate, your blood pressure, and put a lot more stress on your body physically. So if you're someone who already has things like elevated blood pressure, knowing that you're taking a medication that is also helping lower that blood pressure is potentially going to allow us to prescribe you a slightly higher dose of exercise, and see you progress faster because that blood pressure is being kept slightly lower. So it's a way of also keeping people safe when they're participating in things like exercise, and being able to progress through those lifestyle changes in steps a lot faster. So if it's being monitored, if it's being kept in awareness by the doctor or by a practitioner who's supervising you, then hopefully the goal for a lot of people, especially if it is a preventative measure, is to be able to reduce that medication if they are able to do the lifestyle changes to have the changes in their health outcomes. And that's always a great goal for people. So yeah, we do encourage people to actually follow their medication recommendations from the medical professionals for that reason. And unfortunately, a lot of people aren't aware of that. So yeah.
But what we're saying is that medicine has a place in heart health whole order, and everyone's different, right? Everyone is so complex. Everyone has different needs. Everyone is their own unique, special case. What other Anna, from a holistic perspective, kind of Hannah's just kind of touched on understanding of what the medicine is doing on your body and the physiology when we think about exercise when it comes to heart health. But what other holistic components can we think about when we're talking about heart health? Consideration, sorry.
I'm on mute. How long have you got, Nat?
Yeah, short version, please.
Short version, sure. I think I'll probably pick up on the stress point then in terms of the answer to that question. So Karen's right that stress is has a significant impact on our hearts. And when we think about how we might manage stress, this is often where the holistic management of our whole order comes into play. And there's lots and lots of different things. There's so much out there. If you Dr. Googled, how do I manage the stress that I have in my life? Oh my goodness, I'd hate to think what came up. But the reality is that there isn't a medicine to take that is going to reduce the stress in your life. So this is where the lifestyle change stuff comes in, and the holistic management of your health. So exercise is really great for stress management, but exercise is also a physiological stress on our body. So there's a balance in that. We know that the way that our minds work can be really, really impactful on how much stress that we feel in our lives. So you get a crappy email from someone, Nat reads the crappy email and thinks, oh, what a wally, and moves on. I read the crappy email and then I stress about it for the rest of the day and try and figure out how I'm going to reply to this crappy email. And so that's a real difference in our management of a situation that can be stressful. And so the email is just an example of something. It could be someone cutting you off in the traffic. It could be worrying about what to cook for dinner tonight. It can be teeny tiny little things, and it could be really big things, managing a loved one who is unwell, for example. So we can't get rid of stress in our lives. Good luck. If you know how to get rid of stress in your life, can you please come on to the next panel about stress, because that would be super helpful. But perhaps if you want to convert to a religious base like Buddhism and go and live in a monastery, you might find the answer to that question. But what it is for most of us is finding strategies to help us to understand how our mind impacts on our body. So when I read crappy email and get super stressed about it, I've now created a physiological response to a thought, to a perception of the situation. Whereas Nat, who read the email and just thought, what a load of rubbish, she doesn't have that physiological response. But I've got now high blood pressure, I've got a fast heart rate, my sweat glands are working. So I've got this active response, and we're both just sitting at our desks looking at our computer. So in the terms of holistic management of heart health, with particular reference to stress, it's really about understanding how our minds have an ability to change our physical bodies. And if we can start to implement strategies that help us to see how our mind works, then we will help our bodies by having them not be, infiltrated with a huge amount of stress hormone by reading an email from an annoying person.
But that's that simple example of how stress impacts everybody differently is quite powerful. Anna, does anyone have anything else to say in regards to that, in terms of stress on the body?
Well, I think just to kind of take it a little bit further, or a slightly different way as well, is and it gets spoken around a lot, is that stress, regardless of what the stressor is, so whether it's physical, emotional, mental, an email, someone else, it puts you into this, what we call a fight or flight response, which is a physiological or a physical reaction, and our heart is the engine of our physical body. So ultimately it's our heart that has to pick up the pace to prepare for this physical reaction, which is to fight or fly away from the stress, even though we're just sitting in front of the computer mulling over this thing that's not requiring us to quickly jump up and sprint away. Our heart is still preparing for this sprint. And so, and for the likes of Karen, she was literally under that for probably 26 years that you own the business for, Karen. So she was preparing for this fight or fly every day, coupled with poor sleep. So she wasn't getting the physical recovery she needed either to be able to cope and to be able to recover. And so ultimately, even if all of your other risk factors on paper look okay, we have no way of truly measuring the impact of stress yet. And so being aware of what your physiological response is to these situations can help you understand the load that your body's under, and in particular what your heart is under, and then implement obviously things that are going to help with that.
I just want to pick up on your word recovery there for a second, Hannah, because I in my head, and somebody said this earlier, in my head, exercise for me, in my head, that was my downtime, that was my recovery. I work in a really high-paced environment. I work a lot. I work long hours. I've got 10-year-old twins. They're chaotic. My work is chaotic. The way that I personally relax is I'm an active socializer, so I go out, but that's still quite chaotic. In my head, running or my exercise, which is also high intensity, that was my recovery. But what I learned was, actually, that's not a recovery for the heart. So if I mind map everything in my life, the only thing in my life that's not chaotic was my husband. But in my head, kind of my conditioning or my bias or whatever, in my head, I thought like exercising, that was my recovery, but that's not the case, is it?
No. And I mean, you have to remember your heart is a muscle, and so it needs exercise in order to grow stronger, to be able to develop endurance. But when it is literally running and fighting this fight all day, yes, doing some physical activity can be really good to help you close off this stress cycle, because your body is literally physically preparing to fight or fly. But you have to ensure that you're recovering and you're doing something else that is completely switching off this physical and mental stress. So if you're not also doing that recovery aspect where you're relaxing, and if you don't know what it feels like to relax, please learn quickly. So you need to have that something that is allowing your body to actually switch off. And that's not sleep, because you're unconscious. You have to do something consciously to relax as well. And you need to do it frequently. So exercise plays a part. And I think, and actually we talked a bit during our practice as well, is it's really unfortunate that a lot of people end up having these heart events while they're exercising. Karen's case, for example, yeah. And that is because when you are exercising, your heart's working hard. It is. And unfortunately, if there was something there that's already negatively impacting on the heart's function, you put it under stress, particularly higher levels of stress, that is when that weakness is going to be seen. So exercise isn't a bad thing. In fact, it's a really important tool that is vital in the rehabilitation and prevention of all heart-related issues, but it needs to be done safely post-heart attack, and it also needs to be coupled with something else that's ensuring you are recovering as well. And
So-
that's kind of the key one.
Yeah, perfect. Because I mean, again, as Hannah kind of touched on in our practice session, we were talking about, unfortunately, people have episodes when they have a heart attack. Have an episode when they're exercising. Sorry, but why is that, Hannah? Like, I don't think we've kind of touched this. Or Martin, did you want to jump in here in terms of you must see this a lot? I mean, I had a colleague even last week. Something happened where he just went out for a run and he had a heart attack. So what's happening there?
Yeah, I guess I see both sides. I see people having heart attacks on exercise. I see people waking up with heart attacks and having them watching TV and things. And I think if a sports person or someone is or somebody who's out in the community and they're exercising has a heart attack, it's quite a public arena in which to do it. That sort of stuff makes the paper. Whereas, if you're having it over breakfast, not so interesting. So, we do see that. I guess sometimes you have this sort of demand supply issue. So maybe you have a narrowing in one of your arteries and there's enough blood getting through to nourish the heart with oxygen when you're doing nothing. But when you're putting your heart under stress, it's demanding more oxygen and it's just not enough to get through that narrowing. And that's a sort of a demand side heart issue. The other side of it is a supply side heart issue, where that narrowing becomes even more narrowed or even blocked with, a blood clot. And then no matter what you do, even at rest, that heart's getting no blood or oxygen. So you're going to have a trouble there. And sometimes that blood clot can come and go and those sort of things. So, I mean, I in my area of electrical sort of cardiology aspects, we see a really interesting exercise paradox where a little bit of exercise is really good, a medium amount of exercise is really good, but really high-end exercise. And I get this because I'm just up the road from, the Cambridge Rowing and Cycling National Centres of Excellence. You get these people who are sort of exceeding the specifications for which their heart was designed, and they're complaining at the other end, and that's really interesting too. That's not the majority of people, though. I don't know how many people are listening on this are high intensity, high endurance athletes. If you are, good on you, but maybe just bring it back a bit. But for the rest of you, probably more exercise is better, right?
I think so.
As long as you're listening to that, Hannah. Hannah, did you hear what Martin said?
Yeah. Start back, Hannah.
Being the athlete on the call.
Yes, yeah. And getting to deal with a lot of our, particularly the masters athletes who have been endurance trained their whole life and developing arrhythmias and things later on in life.
Yeah, the middle-aged men in lycra.
Yeah.
Yeah, we see them, the mammals, and just about one myself. But one of the really interesting things is that one of the higher risk factors for these rhythm disturbers is high intensity exercise in terms of hours. So once you get above 3,000 or 4,000 hours of high intensity exercise, you can see the risk go up. Now, it's very difficult for a 22-year-old to get 3,000 hours of high intensity exercise, but for a 55-year-old who's been running all their life, they're well there, you know. So and then of course the age risk factor starts to overlap with the exercise risk factors, and we start to see disease coming. Yeah, interesting.
I know you got it. Martin, what is atrial fibrillation?
Yeah, atrial fibrillation. Yep, atrial fibrillation, or AF, as we sometimes call it, is a heart rhythm disorder. It's the most common heart rhythm disorder that's sustained in adults, and it affects about 1% of 50-year-olds and 10% of 80-year-olds. So you can see it's sort of more common as we age. It's a rhythm disorder where the heart goes fast and irregular. And if you, at the moment, sitting here listening to this webinar, you might have a 70 beat per minute regular heartbeat. But if you went into atrial fibrillation, you might be going 120, 130 beats per minute just at rest and irregular. And if you went up and climbed a couple of flights of stairs, it might go 160 beats per minute. So quite a dramatic increase to any exercise. And people tend to feel breathless. Sometimes they feel palpitations. Sometimes they feel dizzy. Sometimes they do get chest pain. But sometimes they don't get any symptoms. Kind of weird. Sometimes people just turn up for their hip replacement and someone does an ECG and they're in atrial fibrillation they never knew. So it's quite a wide range of what people experience with atrial fibrillation. But there's sort of 4 things that we try to tell people about atrial fibrillation. One of them is that AF can, in some people, increase the risk of stroke. And stroke's a devastating illness that I think we'd all want to avoid. So if you do have atrial fibrillation and you're carrying a few other risk factors, it might be useful to take a blood thinner to prevent clots forming in the heart and then traveling to the brain and causing a stroke. The downside of taking blood thinners might be some increased bleeding, but the risk-benefit analysis almost always favors taking blood thinners unless people have got a real bleeding issue. So we talk about anticoagulation. That's one of the things we talk about with AF. Another thing we talk about is lifestyle management. So we know that AF is more common when people are obese. And so we try and get people who are carrying extra weight to lose that extra weight. And that's not an easy thing to do. It's not an easy thing to ask somebody. But I think if you take them through it, you know, I can talk about animal studies that we did when I was doing my studies overseas, but well, I can tell you the fat sheep, they get into AF easily, and skinny sheep, you lose the weight, they don't. And that's another mammal that's not hugely dissimilar to us. So we try and get people to lose weight. Sleep apnea is another one. So people who stop breathing at night when their airway occludes, and they fall asleep, their oxygen levels drop, they get arousal because their oxygen levels low and their CO2 levels are high, and they wake up, they take a breath, and everything goes back to normal. Then they fall back to sleep, and the whole process repeats. So it's not a very restful sleep. And those people can get AF. People with diabetes, people with high blood pressure especially. I think probably the most common cause of AF in the Western world is high blood pressure. And then there are other issues like heart failure, valvular issues. Alcohol is an increasingly recognized risk factor for atrial fibrillation. Coffee, interestingly, the data's a bit mixed on that.
No.
Yeah.
Right there.
Yeah, you're breaking up. I've ground the data. And coffee seems to be not so much a risk factor for atrial fibrillation, which is interesting. But then, everybody knows that if you have too much coffee, your heart goes a bit fast, doesn't it? So it's a bit confusing. So anyway, those are things. So blood thinners, lifestyle management, and then we talk about what we're going to do about the rhythm itself. For some people, we're going to try really hard to get them back to a normal rhythm because that's best for them. For other people, we're going to say, hey, you know what? This rhythm's been here so long, or there's other risk factors that are going to make it hard for us to do it. We're going to leave you in atrial fibrillation. And we're just going to make sure your heart doesn't go so fast anymore, right? So one's called rhythm control, get you back to normal rhythm. The other one's called rate control. We're going to keep you in this rhythm, but make sure you don't go too fast. And that's a sort of an individual strategy that you talk about with your doctor. So those are the things that we talk about. Most of them involve drugs. Some of those lifestyle ones, not so much. And yeah, we try and take people through it. One of the most important things, though, I find when you're talking to someone with atrial fibrillation is it's not a life-threatening rhythm problem.
Can be
So,
managed.
yeah, so some rhythm problems are life-threatening. You know, people have cardiac arrest, it's a rhythm problem, and we have to deal with that. But atrial fibrillation, unless in rare circumstances, is not life-threatening. And sometimes, because people feel terrible, they feel like they're going to collapse. But telling them that sometimes just takes that stress off. And we were talking about stress before. Oh my gosh, got palpitations, I'm getting stressed. That drives the heart faster. That stresses the patient out more, and it's a vicious cycle. So just trying to reassure patients that it's not a life-threatening rhythm problem. We can control the risk for stroke. We can slow their heart rate down. They can do things to help themselves. That's kind of where we start with atrial fibrillation.
Awesome. And you've kind of spoken about environmental factors, and I don't know if there's hereditary AF considerations, I guess, if you're talking about your heart health. But what's the difference between hereditary and environmental? Because I think some people are like, and Anna mentioned it earlier in the korero, you know, oh, my uncle had heart disease, my mum, my cousins, my uncle's auntie's brother had it, so I'm just going to get it and there's nothing else I can do about it, so that's my lot. But that's not really the case, is it?
Yeah, so in heart health in general, I guess we're all dealt a hand of cards from the genetic deck that we go through life playing with, right? And so some of us are going to be more likely to get heart disease, others might be more likely to get cancer, others might be getting other diseases, right? And so it might be true that if your mother and father or your brothers and sisters have heart disease, that your risk is increased. But what we said before is that we share often the same risk factors with our family, the same environmental risk factors as our family, along with genetic risk factors. And I guess if you were to think about somebody with diabetes, it's really important for the person with diabetes to think about their cholesterol and their high blood pressure and their smoking, because they've already got diabetes. Similarly, if your dad has heart disease, then probably you should be thinking more about what your risk of heart disease is than someone whose parents don't have heart disease or live to a ripe old age. So I guess it's all about managing risk factors. And I guess this is really the work that Katrina's been doing to try and, for New Zealanders, and Katrina's data is New Zealand, which is really important, for New Zealanders, what is your 5-year forecast for your health? What is your 10-year forecast? And taking all those things into consideration, because overseas, they just talk about, this is your cholesterol level, we should do something, this is your blood pressure level. But I think what we're trying to do is look at the big picture.
Katrina, do you want to jump?
Yeah, definitely. Well put, Martin. I mean, that is the difference. Overseas, it's single factors. And you know, if your cholesterol's high, we'll take a drug and off you go. Whereas New Zealand actually has a really mature approach to cardiovascular risk assessment, just the way individuals kicked this off 15, 20 years ago. And it's really well developed here to look at the composite. So adding up the different combinations of risk factors that people have and trying to personalize that to say, well, this, as a person in front of me here, this is your risk of having, and quantifying it and really identifying that combination of factors. So you might have mild increase in cholesterol, a mild increase in blood pressure, not have diabetes, that's one combo, you know, or you might be a smoker and be really overweight and be, you know, your strong family history that your mum and your dad both had heart attacks at a young age and all this, and that puts you at yourself at a higher risk. And so by doing that, it's identifying what, you know, personalizing it more, coming to you. And in New Zealand, we include a socioeconomic situation, which is, you know, a metric of where people live. And it's not great, but it gives an idea of, you know, the extra stresses that people might be living under, socioeconomic disadvantage. And also ethnicity, which is a global, you know, very umbrella term, but it's trying to just, we see that different ethnic groups just generally have a different type of risk profile. Now, individuals within that are different, everyone's an individual, but there's an element that we can just, you know, just try and design this risk estimation more for what is like in New Zealand these days as well. It's not out of date, it's quite recent as well. So we've got quite a well-established, well-respected body of research going on there, internationally well-respected. So we're doing quite well in New Zealand to try and really personalise risk prediction. And adding to that, and it's a continual area of research. And so one thing is, we're getting close to time too, aren't we? One thing is, say for ongoing research, so we had these established risk factors that we know about, that we've been talking about: diabetes, smoking, high cholesterol, blood pressure, age, risk increases with age. We're also looking at trying to add other risk factors just to get even more accurate, for more personalised. And so, for women, for example, you can have some of the complications that women can have during pregnancy can influence, either be associated with or lead to, no one knows yet, but associated with increased cardiac risk. So if you have high blood pressure during pregnancy, or if you have diabetes just during pregnancy and not after, they're still associated with an increased risk of having a heart problem later in life. If you have preeclampsia, it's very rare, but women who do have preeclampsia have a higher risk of having a heart attack later in, within the next 10 years. So if you're pregnant when you're 35, you're at higher risk of having a heart attack before you're 50. So it's in that younger age group. That's all in the research area. It's not implemented. But I do just encourage women, just to get my message in, about women, that if you do have, again, a bit like we said before, women think that heart disease doesn't affect them because it is a different, a lot of it. I was going to say a lot of attention is given to men. That's the wrong wording, but we know men are at higher risk of heart attack. But for women who do have complications during pregnancy, please do go see your doctor. After, don't just think, I'm fine, I'm in my 30s, got my kids to look after. 20 years later, but like my friend I mentioned at the beginning, she hasn't been to a GP for 20 years. She's been with her kids, but not for herself. She, as an example, had high-ish blood pressure during her pregnancy. She should just go off and get checked. That's all you need to do. Just get checked out, contact your GP and say, I've had this complication of pregnancy. I just want to check out my heart risk and be monitored. Just keep an eye on things, because you can introduce interventions and strategies for yourself. We're talking about exercise and stress, these medications that can help, these, all these things that we've been talking about tonight. This morning, I just about said for my time zone. Sorry. Caught myself just in time.
It is morning somewhere. But that's perfect segue into kind of, what we like to do at the end of the kōrero is, I'm going to pick on everyone. What is your one thing that if you could impart to everybody watching at home, what would that one piece of advice or information be? Katrina, what would yours be?
Don't be afraid of going to your GP. Going to a GP, find one if you don't have one. They're not bad. And just to get some measurements done, just to get your state of play, like a warrant of fitness for how your heart health is looking.
Amazing. Karen?
For me, I think stress, I just really didn't fully understand the fight and flight, how important that is, I suppose, that the stress that my body was under for all those years. One, I didn't realise if you were in that state that you couldn't lose weight very well. So that was one. And I think why I went to the centre in the first instance was because my heart was still racing after or during exercise after I'd had my heart attack. And it was actually, I was frightened. I was frightened of having another heart attack, and it seemed that my heart was still in that fight-flight mode to a degree. And by being assessed by Hannah, a program was developed to bring my heart rate down. So, yeah, that's what I would say. Just if you're under stress, you just need to go and get it checked out.
Go and get Hannah to mend your broken heart. I love it. Hannah, what's your last piece of advice?
Oh, I could borrow that one. No, I won't. My one's definitely that knowledge and awareness brings confidence, and that you have the ability to control everything. So seek the people that you can trust, the information that they can give you, and you can actually take control of your life and your heart with those. Yeah.
Awesome, Hannah. Well done. Martin?
Yeah, difficult for one message, isn't it? But I guess just listening to what other people are saying is that there are some things in the life, like we talked about risk factors, and we talked about familial risk factors or genetic risk factors. And to be honest, you can't control those, can you? There is some gene therapies being developed. It's something that's really exciting, but in the whole, you can't choose your parents. And you've got those genetic cards that you've been dealt. And you might not be able to change some of your stresses in life, some of your social situations, some of your financial situations, that sort of stuff. But there will be things that you can control. And those might be your blood pressure. Those might be your weight. They might be, I don't know, other things in your life, even going to see a GP. So I guess when you're talking about stress, one of the things that I used to do is, worry about everything. And one of the things I try to do is worry about the things I can control and not worry about the things I can't control, because that's just wasted mental energy. So I don't know. Is that one message? It's about 10 probably. Sorry.
No, I love it. Total call that. Don't sweat the small stuff is what I'm hearing. Control and do what you can only. I love it. Anna, did you want to close us out, please?
As per usual, Hannah stole mine. This happens every hauora kōrero. Thanks, Hannah, for stealing that. And then I can't think of something. I think my one last little bit to leave everyone with is actually you can. If you think you can't, then that's not right. You can. So if you're thinking I'm really unwell, or everyone in my family has heart things, or I've tried before and it hasn't worked, or that whole I can't do this. Actually, teeny tiny little steps, and everyone shared lots of things that can be teeny tiny little steps, or as Nat said at the beginning, little nuggets. Just grab one nugget and take a step, and that will start to help improve the situation for your heart. Whether that's a physical thing, like actually taking the medicine that you've got sitting in the cupboard, or going out for a walk tomorrow for 15 minutes, giving us a call and having a catch up with Hannah, or thinking about the fact that you are that person that goes around in your head about a crappy email and how you might think about that differently. Just one little thing from tonight and move forward with that, and that'll be super helpful.
Oh, amazing. Thank you to our panel for their amazing whakaaro and expertise. I hope our whānau listening at home was able to take a little piece of information, exactly what Anna's just said, and hopefully implement it in your life for better overall health, and even more specifically heart health. So Pomari e whānau, thank you so much for logging in tonight and listening to our panel, and we'll see you next month for another Hauora Kōrero. Ka kite, Pomari e.
Pomari e.